Yes.
And will you stop
Yeah.
us if we're out of time?
Okay, it's time. It's time. So I would like to introduce the today's webinar first. So good morning and good evenings. I'm P.Y. Cho, and along with my colleague Dr. Junior Tu, will be moderating this memorial 100th ICC webinar today. The International Craniofacial Chang webinar, ICC webinar, started in November 2020, addressing unanswered questions from the virtual Chang forum. And over 4 years, the ICC has hosted speakers from 20 nationalities with an average of 94.7 participants across 99 webinars. We appreciate your long-term support, which inspired us to continue and attract more participants. Today, we will hear from 4 esteemed mentors who have previously been invited to lecture our participants. They are Professor Brian Sommerland, the honorary consultant plastic surgeon at Grand Ormond Street Hospital for Children, London, United Kingdom. Professor Roberto Flores, the director of the Cleft Lip and Palate at NYU Langone Medical Center, United States. Professor Ghulam Fayyaz, General Secretary of the Cleft Lip and Palate Association of Pakistan and the CEO of Cleft Hospital, Lahore, Pakistan. And Professor Lun-Jou, my mentor from Chang, and the immediate past president of the Asian Pacific Craniofacial Association. Today, we will tackle the complex issues of cleft care in velopharyngeal dysfunction. Each speaker will have 20 minutes to share their insight. In the following order, Brian, Robert, and Ghulam and Lun-Jou. After their presentations, we will discuss maybe 2, maybe 3 questions from our audience. The entire webinar is scheduled to conclude within the 2 hours. So let's first welcome Professor Brian Sommerland to present. Thank you, Professor Brian.
Thank you very much, and thank you for the invitation to be part of this historical 100th webinar. So I've called this a personal journey in cleft care in velopharyngeal dysfunction. I'm going to use VPI rather more than VPD, although I know that many people feel that they should be classified separately. So when I was a resident in 1974 in the UK, VPI after cleft palate surgery meant virtually always some form of pharyngoplasty. And the investigations available when I started were basically still X-rays, cephalometric views. In 1974, I visited Ron Piggott, a plastic surgeon in Bristol in the UK. He had worked with Ralph Millard and developed their endoscopy. It had been tried before, but Ron really popularized it. And that was done with a rigid endoscope. And this is me in about 1974 with this poor child with a rigid endoscope, a complicated way of trying to record it on that video camera, which is much less powerful than everybody's mobile phone is now. But this was my first attempt to look at palate function. And what I found was that many of these patients had very poorly functioning palates, often with central defects, a concave posterior border of the soft palate, evidence that the muscles were inserted anteriorly. I'd read a little about the anatomy of the palate. I'd read Krian's, and in fact visited him later. So I used to suggest to my bosses, why don't you first of all re-repair the palate? And they would say to me, well, you do it. And so I actually learned palate surgery, re-repairing palates. And this is the sort of appearance that I'd often find with anterior. This is actually the platopharyngeus muscle, but anteriorly inserted muscles. And I began fairly conservatively dissecting those muscles, retroposing them, later on realizing how important it was to divide the midline scar, otherwise the palate wouldn't extend. So endoscopy was the beginning for me and does have many advantages. It shows the shape of the velopharyngeal aperture. It shows you asymmetry, pharyngeal wall movement. You can see the adenoids. You can see the shape of the nasal side of the velum. You can see pathology and pulsations. But it's difficult in small children. It's optically distorted. You look through an endoscope at a bit of print and you realize how distorted it is, and it's not quantifiable. And very importantly, you can't assess vertical relationship. At about the same time, particularly Skolnick and others were looking at what was called then cine fluoroscopy, because videos were virtually not invented. And this was one of those early papers. And lateral video fluoroscopy has great advantages. You can do it in young children. Very importantly, it's quantitative. You look at this relationship between the palate and the pharynx, the length of the palate, the size of the defect, the vertical relationship between palate and pharynx, and also what the tongue is doing. Disadvantages, there is radiation, and you obviously don't see lateral pharyngeal wall movement and asymmetry. We started doing lateral video fluoroscopies with an image intensifier, and very early on, and wrote up the use of this very simple device, a child's ViewMaster, to keep the head still so that you obtain maximal information in the shortest time. And on lateral video fluoroscopy, you can learn many things. You can see here the velum and the posterior pharyngeal wall. You can see where the levator knee is. You can see the point where the levator insertion is. You can see lateral posterior pharyngeal wall movement here, a passavance ridge. You can see that vertical relationship. And you can make measurements. And we wrote several papers about measuring palate length, the size of the defect, palate extensibility, the velocity of palate movement, velar movement. So this was the standard sort of setup with the ViewMaster. This is a little 2-centimeter ring in the mid-sagittal plane. And if you take a picture of that at the beginning, you can then make actual measurements. You can say this is the size of the velopharyngeal defect is 1.5 centimeters. But in many places where I work in low and middle income countries, that sort of image intensifier is not available. But most places have a C-arm, and you can get a very good lateral video with a C-arm and then just record it on a phone or a camera. So here's a 3-year-old girl with a repaired cleft palate. Here she is saying E, and you can see the gap and the point of the levator knee. And at operation, the oral mucosa lifted, and that anterior insertion of the muscles. In this, initially, what you're looking at is palatopharyngeus, and then more posteriorly and much deeper, closer to the nasal layer, the levator. Here, the left levator, and closure in the midline and division of that midline scar. So here she is saying E before, re-repairing the palate, and afterwards, with the levator knee moved from there to there. We first published the technique in 1994 in the British Journal of Plastic Surgery, and a re-look at the results in 2002 in the Cleft Palate Journal. From 1991, I've, wherever possible, used an operating microscope for all of these procedures, including re-repairs and pharyngoplasties. So here's a palate before re-repair and after re-repair, saying E, which is the best sound for demonstrating palatal velar movement. And here's the same patient at rest. before and after. And the great advantage of re-repair over pharyngoplasty is there's no significant narrowing of the velopharyngeal orifice at rest and no risk of airway obstruction. So this was that in that second paper in 2002, 85 patients, each patient registered horizontally, nasality, nasal emission, nasal turbulence, scored independently by two external speech and language therapists, speech pathologists, scoring from normal green, mildly abnormal yellow, moderately orange, severely abnormal red. And here's one patient before re-repair, and you can see the position of the levator knee. And after. In that series, no significant complications. One partial dehiscence not requiring surgery, no hemorrhages, no sleep apnea, no, at least on history, and no obstructive nasal symptoms. And for 90% of the patients, one low morbidity operation. So this was what I would call a physiological approach. First, maximize velar function, try to avoid a pharyngoplasty, reassess. If VPI is still present, some form of further surgery. Early on, that was usually a Heinz pharyngoplasty. A Heinz pharyngoplasty is nothing like an autocachea or sphincter pharyngoplasty. I call it a posterior wall augmentation pharyngoplasty. You have to split the velum to put the flaps at the right level. They're mucomuscular flaps from the posterolateral pharyngeal wall. They're overlapped, one above the other, and they're inset high on the posterior pharyngeal wall, and you decide that level based on lateral videofluoroscopy. Heinz first published the technique in the British Journal of Plastic Surgery in 1950, and others have looked at it since. If you look at this sagittal section of a cadaver, you see that to put the bulge where you need it for palate movement has to be very high, well above the arch of the atlas. So here's a patient, repaired palate split, arch of the atlas here. And these flaps are raised almost to the level of the eustachian orifice. So two parallel incisions on the posterior pharyngeal wall, and then more lateral incisions to raise two posterolateral flaps. And one is inserted across here horizontally, and one, well, they're both inserted horizontally, one above the other, simply creating a bulge, in a way, recreating the adenoids. So here's a patient, there's no sound on this, but just to show you, this is a patient before a Heinz pharyngoplasty and after. And you'll see that the palate is actually lifting up and, in fact, pushing up that bulge on the posterior pharyngeal wall. Felicity Mahendley, when she was working with me, looked at a series of Heinz pharyngoplasties. Most of them were being done between the ages of 5 and 10. Or even older. And this was, again, externally assessed outcomes for nasality, two different observers, before and after, and hyponasality. And that's one thing about this operation. It is not a significantly obstructing procedure, although Felicity has shown that there were some subtle changes. I've only had one patient following this procedure with clinical sleep apnea, which did recover. But we gradually moved towards using the buccinator flap as an alternative, really from the early 2000s. So if the levators are well positioned posteriorly and there's good velar movement, but it's just too short, and sometimes even after tumor resection, then this is the technique. The a transverse incision or curved incision behind the alveolus and across to the other side, and then separation of the oral and nasal layers, and the two flaps raised below here, the left flap below the parotid duct, and so one flap inserted on the nasal side, one on the oral side. There are some who feel you don't need both. That's not been my experience. At least I think you get more effective lengthening with both. A series from our center, these were not all my patients, that my colleagues as well, was written up by Greet Hens in 2013, showing the way the buccinator flaps are inserted. In this series, the patients had bite blocks so that they wouldn't bite the pedicles, and the pedicles were divided after 3 weeks. I no longer do either of those things. These were a very syndromic lot of patients. 81% of them did not need any further surgery, but 19% did go on then to have a Heinz pharyngoplasty. It's an easier operation to do. I think it has less significant morbidity than a pharyngoplasty. And certainly when I'm operating in countries, I've just come back from Pakistan and Bangladesh, but when I'm operating in Bangladesh, for example, I'm unhappy about doing a pharyngoplasty. We've had two, although in this series there weren't any, we've had two secondary bleeds after Heinz pharyngoplasties. The disappointment about the buccinator flap is that although you might put in a flap which is 15 millimeters wide, when you look at these, when you measure them post 6 or more months later, mean lengthening was only 7.5 millimeters. But nevertheless, the gap closed in 77% of patients. And looking at this group, their speech evaluated again externally, before on the left, after on the right, including in this case articulation, cleft type characteristics before and after. You can see that the range of outcomes, again, not all perfect. And interestingly, a little increase in nasal turbulence, implying a very small residual defect. This was actually a tumor patient. She'd had a pleomorphic adenoma removed from her soft palate, before on the left, after on the right. And it's a very useful flap for reconstructing very deficient palates. If associated with a fistula, the flap can be designed to repair the fistula. And if the muscles have not been adequately retropositioned, then this operation can be combined with a re-repair. So an incision around the same incision as shown previously, but also around the fistula and extending back in the midline of the velum. And then these flaps of velum are then turned back, giving very good exposure for muscle retropositioning. And so here's this patient with the flap designed, the left flap designed with an extension to cover the fistula. So just to finish, my personal protocol for the management of VPD or VPI. If the muscles are anterior, if the levator is inserted anteriorly, the defect is coronal, the palate appears long enough if the muscles are retrodisplaced. So the levator anteriorly inserted, a coronal defect, often concave backwards, then a re-repair with retropositioning of the levator and with uniting the levators beneath mucous glands which are left on the nasal surface of the palate to create a convexity. That's what you hope to see. If the defect is coronal and the muscles are posterior, have been well positioned primarily or secondarily, but the palate is too short, so the muscles and the levator in a good position, perhaps quite a nice convex soft palate on endoscopy, then buccinator flap lengthening, simply dividing the soft palate and putting two flaps, one above and one below. Or, but less and less frequently these days, same problem, a modified Heinz pharyngoplasty. if the defect is coronal, the muscles are anterior, but the palate just looks too short to achieve closure. So muscles anterior, but the palate, even if you imagine if you move those muscles back, they're not going to be, you're still not going to have a competent palate. Then you can combine re-repair and buccinator. And I mentioned PPAP, posterior pillar augmentation palatoplasty, which I have been developing, but which I don't have time to talk about. So there, what you're achieving after, hopefully. Infrequently, in those patients with a sagittal defect, poor soft palate movement, good lateral pharyngeal wall movement, but this sort of situation, not very common, then I think there is an argument for a midline posterior pharyngeal flap. And occasionally, and usually temporarily, in a coronal defect with a long enough palate with limited or no movement, then a palate lift, perhaps temporarily, or if the defect's just too large for a lift to achieve closure, an obturator, a bulb. So this is my attempt at an algorithm, and I've sort of explained that in a more simple way. This is a book which I co-wrote with co-authors, and there's a chapter in there about re-repair and buccinator flap lengthening. And you can obtain videos of Heinz pharyngoplasty, re-repair, buccinator flap if you go to our charity website, www.cleft.org.uk, go to international projects, online training for surgeons, and you can request full-length videos of those procedures. Thank you very much.
Thank you very much, Professor Brian Sommerland, for that very, very in-depth explanation of how to deal with the conditions. And next, I'd like to invite Professor Roberto Flores. Professor, the floor is yours.
Can you hear me?
Yes, yes, we can.
Okay. Thank you. And thank you again for the invitation to speak. This is a lot of what I'm going to talk about is going to build on what Mr. Sommerland has stated. Actually, I agree with so many things that he said, and I'm also going to take it maybe a kind of a step further in terms of our concept. I would also like just to really acknowledge the great work and the great people at Chang. They're a group that have been kind of near and dear to me. And there's a picture here with you, Ray Chen, and I when we were visiting professors in Madrid, kind of eating our way through the old Madrid. And on the right side, a picture of one of the many numerous visits, to NYU. Our professor, Dr. Eduardo Rodriguez, trained in Chang'an, as a microsurgeon. And then, of course, I just had the pleasure of meeting Peng Yun very recently in Milan, finally, after many numerous discussions. But this talk is really going to be directed. We only have 20 minutes. So a comprehensive review of VPI is not possible. So therefore, I'm going to talk about first a brief evolution of cleft palate repair and because I think that's important because that informs VPI treatment, and talk about the management protocol that we're following. It's really more of a conceptual approach than really an algorithm. And talk about a technical variation that we've developed for difficult cases, and then recommendations, maybe a statement of thought about recommendations for fistula reconstruction. So if we were going to kind of do a very directed history of cleft palate repair, really first, in the early 1800s, closing the hole by Diefenbach and others. And then the next step was really kind of pushing back, Waldo Kilner, pushing back the soft palate, the first appreciation that actually length is important and we do need some palatal length. Then, as Mr. Sommerland has mentioned, the work by Creans in terms of the intravelovialoplasty that was later developed further by Dr. Cutting, Mr. Sommerland, for a very anatomic reconstruction, radical intravelovialoplasty, Sommerland repair, however you want to call it, of the soft palate, which many people call it the straight line repair, which I don't like. And then, of course, the work by Leonard Furlow for the double opposing Z-plasty, which is really about anatomic muscle repair, right? And these were the champions of this. And then lastly, restoring palatal excursion, the work by popularized by Dr. Robert Mann. And in this case, for this evolution is really talking about soft palate repair. And I know Dr. Mann uses for primary palatoplasty, buccal flaps, and the hard palate. This is really about his use of it in the soft palate, which I agree with, which in certain cases, there is a need to restore excursion. We can close the palate, a very wide palate, and bounce a dime off of it. That palate really will not move. So the whole idea of palate excursion is actually, I think, an important concept. But when we talk about VPI, there's actually a lot of challenges to this because the approaches tend to be technique-based, and surgeons tend to be very adamant about the techniques that they want to do. And since that can be the case, there can be a big bias to indications. And what happens is certain approaches are not really generalizable because someone says, "Oh, we need to do a sphincter or some other kind of specific revision repair," and maybe there is a better way to kind of have this discussion. The other part that I don't like is that there really isn't a discussion on a sequential approach, and I think that's really important because our first intervention may not work. I know that there's some patients that I treat that still need more surgery, and Mr. Sommerland alluded to the need for further surgery in the future. There are very few people who speak like that. Many times when I hear VPI talks, people are talking as if this procedure is definitive, and we know that not every procedure is. So how do we formulate a stepwise approach and set ourselves up for the next surgery if needed without burning a bridge? And I think that's something that we have to bring more into the forefront of a discussion of VPI. And then also, as Mr. Sommerland mentioned, the limitations of trying to limit OSA, trying to limit obstructive sleep apnea, which we all see, and how can we formulate an approach that limits this? So the process that we're following at NYU is a VPI surgical approach based on 3 principles: by categorization, by concept, and not technique. And that way we can limit technique and training bias. It can be more broadly embraced, and it can be applicable with new or modified with new techniques, or as techniques get modified. Not necessarily you have to do this surgery, but this category of surgery for this kind of problem. Also a stepwise approach, because your first surgery may not work. So how do we see a patient that may be a bit more difficult and say, I may have to do another surgery after this because I'm not that good. How do I do this and still set myself up for success and limit the effects of OSA? So our progression of intervention is really based on the following questions. Which are our more anatomic surgeries? How do I set up the next surgery if I need it? And what choices help me limit airway obstruction? This is also an informed approach, meaning that it's not just a surgeon saying, this is what I think, because VPI treatment really takes a team, not just a surgeon, but a speech. I have a fantastic speech therapist, Meg Lico, that I work with. And then also I have an airway specialist. And the 3 of us put our heads together and came up with this kind of sequential approach. And I think this is also very important for VPI care. So first, how do we categorize a patient? So basically, it's regions of the palate and principles of effect. We have the surgeries that we're doing on the soft palate itself to reorganize the anatomy there. We have the procedures that we do at the junction of the hard and soft palate to potentially lengthen that area. We have the procedures that are more pharyngeal based, where we're transposing soft tissue flaps into the area. And then we have other ones where we're putting tissue of some type in the posterior wall, right? Those are kind of the four categories of surgeries. If I think about surgical, this is not, this is surgical transpositions. Of course, there's bulb and such things, but this is essentially surgical transpositions. And I rate these by the following characteristics: how anatomic they are, what are the risks of obstruction, and which gives me the better opportunity for doing additional interventions. So let's first talk about revision surgery. Furlough, radical IVV, used to address malposition of the levator. Classically, you see a V-shaped deformity of the soft palate. Pretty anatomic, right? We're restoring anatomy that's disturbed. It has a known low association with airway obstruction, meaning that there is no palate surgery that does not have a risk of airway obstruction, but this tends to be on the lower side because we're not we're not closing off the posterior pharynx. So lower risk. And you have other interventions, essentially every intervention at your disposal, including another re-repair if you need to. So you have everything at your fingertips. One of my pet peeves, and I just kind of have to say this, I have using this platform. Some people say they use furlough to quote unquote lengthen the soft palate, which actually makes no sense at all. You're using a furlough or any kind of re-repair to reposition the muscle. So if the levator sling is intact and you have a short palate and you use a furlough, you will mutilate the palate. And I've treated patients like this, and it is bad. It's a crippling situation. So use furlough or any re-repair really to reposition the muscle, full stop, right? And this is just a picture showing, if you think of your mind that the levator is in the inadequate position and you do a furlough, you will mutilate the palate. Interposition lengthening PLAPS, that's buccal flap and its variations. It treats a foreshortened palate, restores palatal excursion. So it's largely anatomic, meaning that you're not repairing a distortion, you're augmenting what you feel like is missing. It treats length, so there should not be theoretically an obstruction of airspace. I've done many of these. Many of us have done a lot of buccal flaps. The risk of airway obstruction we know is pretty low compared to other techniques. Now, if you want to do a subsequent palate revision after you do a buccal flap, that's actually not too easy. It's not possible to do a furlough if you're a furlough person. I've done IVV type procedures, but it's actually not too easy. But you can do other procedures. So you could do most interventions, but it's better to do a buccal flap either before or concurrent to a revision, not unlike what Mr. Sommerland does. Then there's a pharyngeal soft tissue transposition, pharyngeal flap, sphincter palate and its variations, which transposes flaps into the airway. It's not anatomic, right? We know it's not anatomic. It closes a pharyngeal airspace, so there can be an obstruction to obstructive sleep apnea. We have to think about this. And you really don't have many surgical options afterwards other than taking it down or tightening it. So you should see this as a terminal procedure. And I know it sounds like a lot of negative things. And to be clear, these are very effective procedures. I use them a lot, but we have to think about these realities when contemplating these procedures. And I'll get into that, how we think about that. And then there's pharyngeal implants. And I would say probably the Heinz probably fits more into this in the pharyngeal-based implants. They're not as common, but important treatment options, can be potentially effective. I think it's a lower association with obstructive sleep apnea. You can use implants. I'm not a big fan of that. And you could certainly use fat or other sorts of tissue transpositions. I would say largely anatomic, low risk of obstruction. And you can do most interventions. You can do these concurrently to other operations in certain cases, especially if you're doing a fat injection. So then how do I think about these from a standpoint of categorization? Well, revision surgery, it's pretty anatomic, low risk to airway, and we can do other interventions. Interpositional implants, sort of anatomic, low risk to airway, and we could do some intervention. So a kind of a medium. Pharyngeal transpositions actually is not anatomic, high risk of airway obstruction, and more of a terminal procedure. And then pharyngeal implants, largely anatomic, but lower risk to airway, to do other interventions. Now, this has nothing to do with effectiveness, right? These are all effective operations. This is how I think about them in a sequential order, particularly in more difficult cases. So my progression of intervention is considered by the anatomy, providing opportunity for more surgery, limiting risk to airway obstruction, and note that I have not talked about the visual-fluoroscopy or nasoendoscopy. It is a consideration, but is not a primary driver in this conceptual approach. So when I think of a patient who has a levator sling that is inadequate, but the length is appropriate, I'm thinking about doing a revision palatoplasty. I think most of us would agree with that. Independent of closure pattern. I wouldn't want to see the closure pattern, but it was independent because I'm going to do re-repair anyway. Furlough or radical IVV, Sommerland repair, and I know furlough to quote unquote lengthen the palate. It's to reposition the muscle, right? If the levator sling is adequate and the problem is length, I have to think about the airway and the possibility of doing other surgery and avoiding OSA. So if the gap is large, I am not thinking about doing a pharyngeal type flap or pharyngeal type transposition because that will create obstructive sleep apnea. So I really want to lengthen more of a buccal flap. If it's a small central or coronal gap, dealer's choice. Whatever you feel like you want to do in terms of a pharyngeal-based sphincter, palatoplasty, Hines, fat implants, as long as you feel like you can do it in one surgery and it's a low OSA risk. So I would say if it's a patient has more than a 30% coronal gap, I will no longer think about doing a pharyngeal flap. I'll think about doing something else if I can. And then finally, patients who have a levator sling that's inadequate and a problem is length, as Mr. Sommerland's mentioned, we need to do both, either stage or concurrently, and I'll get into how we do that. So what's the role of nasoendoscopy, velopharyngeal? It's fundamental. I know I haven't mentioned it yet in this talk, but it's fundamental. We do this in all our patients we're considering doing surgery on. It confirms the indication for surgery. You should do it to also to follow your effectiveness of your results and improve your craft. But for us, it's actually more important for choosing the type of pharyngeal-based flap, ruling out the use of that kind of procedure, or a posterior wall augmentation. So in terms of an algorithm, it's really more like a framework of how we look at the categorizations of surgery. We assess muscle position and palatal length. A V-shaped levator with an adequate length, of course, we do a revision palatoplasty. If the levator is intact, but your palate is short, if it's a small pharyngeal gap, these are actually pretty straightforward procedures. It's really dealer's choice. And it's a matter of whatever your preferences are there. But if the gap is large or a medium-sized gap, then you really have to start thinking about lengthening through a buccal flap. And certainly if you have a small pharyngeal gap, you could do a buccal flap as well. Again, dealer's choice. And in a V-shaped deformity with a short palate, then you have to do a revision and a palatoplasty at the same time. So what do we do in these cases when we have to combine them? So here's a patient with 23-year-old bilateral cleft lip and palate transferred to us for care and has significant nasal air escape. And this is a patient that we would have kind of a larger risk for obstructive sleep apnea. So this is about a 60% gap in the pharynx. And you see the little divot in the midline. So this patient, in my mind, needs a lengthening and a revision. So let's talk about combining these procedures. So let's do a buccal, if we're considering doing a buccal flap and a revision palatoplasty, if you decided to do this using a furlough, the geometry doesn't work. That you'd be ended up transecting the mucosa-only flaps if you did this concurrently, both on the oral side and on the nasal side. And you could compromise that. You could get around that by making shorter cuts at the junction between the hard and soft palate, but then you're gonna have inadequate length. So but then you could also do this doing a radical IVV. However, you will create a vertical midline scar. And although I do not have a problem with this, I hear this from the furlough people, and I respect that that's a consideration. So someone could criticize this for predisposing to contracture. So is there another option for a combined approach? And this is an approach that we developed here at NYU that I call a arrowhead palatoplasty. And basically, it's bilateral symmetric, posteriorly rotating triangular flaps. Okay. And what this would do is you create a cut along the oral mucosa and and transpose the muscle of the levator posteriorly, but keeping the nasal mucosa intact completely, and then horizontally transecting the nasal mucosa. There's no incision along the midline, and therefore you're able to transpose everything back posteriorly without risk, with lesser risk of contraction, and then bilateral mucosal flap reconstruction. So what are the advantages? Radical posterior rotation of the levator sling. It preserves the muscle and mucosal attachments on one side of the oral mucosa, advantages that we see in the furlough. But unlike the furlough, this can be geometrically applied with a buccal flap. That's not possible with the furlough, and it avoids full thickness midline mucosal incision. So here's a video demonstrating what this procedure would look like. Here's a patient with a V-shaped deformity, a foreshortened soft palate. Of course, we can do just a buccal flap on this patient, but as Mr. Sommerland has mentioned, you need a primary muscle re-repair as well. The markings are similar to what we would do: posterior nasal spine, hook of the hamlet on the right and left side. And then we're going to create a inverted U line at the junction between the hard and soft palate, leaving a cuff of soft tissue in order to reconstruct the defect with buccal flaps. These incisions will go through oral mucosa only, stopping at the nasal mucosa. And here's our midline incision. Of course, we want to provide appropriate local anesthesia. So here's our incision. So for those of you who are for furlough people, think of these as symmetric, posteriorly rotating oral mucosa muscle flaps, right, on each side. So we're going down to the nasal mucosa, going all the way back. For people who embrace the Sommerland repair, this provides an opportunity not only to do a thorough muscular reconstruction, but remove all attachments, aberrant attachments to the posterior end of the hard palate. You can cut the tensor tendon and remove all the scar to the lateral aspects of the soft palate, which we see in our repairs. And I want to be able to have that kind of transposition at the end of the case. We do a similar dissection on the contralateral side. Again, transection of the tensor tendon, it's been inadequately addressed, removing all scarred attachments of the muscle to the soft palate and the lateral aspects of the palate. And then we do a primary muscle repair. Sometimes I trim a little bit of muscle, do a muscle overlap, but do really an adequate reconstruction of the levator sling without a midline incision. And then here's the oral mucosa reconstruction. And then we pretty much progress to a classic buccal flap type of reconstruction. Those of us who do this are familiar with this aspect where we're cutting the nasal mucosa and you see how far back everything goes. Again, about a centimeter to centimeter and a half space in an adult. Here are two buccal flaps. It's very important to have them at a very good, robust thickness. I do think that there can be contracture if you do not dissect these flaps appropriately, and that is a risk for sure. And then we inset on both sides. I do agree with Mr. Sommerland, nasal mucosa and oral mucosa both, or else you're not getting a full result. And then here we are at the end of the procedure. And what you see is we have a significant length, about a centimeter and a half length with adequate muscle restoration. So here's at the end of the surgery, here's where the patient is before, and you see after the lengthening that we're able to get. Here's a patient, that same patient before surgery, somebody. someone who would be otherwise at high risk for obstructive sleep apnea. This is the same patient afterwards.
Key or cake? Good.
No
Yeah,
intervention,
yeah.
no intervening flaps.
Aggie.
And certainly there is a very small gap there that we offered to do a small pharyngeal flap. The patient was very happy with their speech and they decided to defer at this point. But this is someone who we really low risk situation. We went from a high risk situation to a very low risk situation with creating obstructive sleep apnea.
Good.
I would just like to end with thoughts about VPI management and complex fistula repair. When I see patients who haven't had a complex fistula, let's say that usually the VPI rate for palatoplasty is about 7%, about 5 to 7%. If you follow them further, sometimes you can get a bit more. However, if they have a complex fistula, in my experience, is up to 50%. And this, and with a very large fistula, speech evaluation is not always possible. And these patients have a high risk for loss of domain of the soft palate because there's anterior displacement of the soft palate due to the scar contracture. So I would like to pose this question to the audience of, should we opt for more morbid flaps to close a hard palate and save the buccal flap for restoration of soft palate excursion, because it's probably compromised in patients with a large and complex palatal fistula. I'd like to end to inviting all of you to New York City. I'll be hosting a conference on advanced topics of cleft surgery, really uniting a lot of the masters. Dr. Lowe will be also one of my guests, amongst other surgeons, this March 5th and 6th, 2026, not this year, 2026, in New York City. I will distribute the invitations through the Chang Forum when they are available. I appreciate your attention and thank you again for the invitation.
Thank you so much, Professor Flores, for walking us through the NYU protocol for VPI surgeries, and that was really amazing. Next, I'd like to invite Professor Fayyaz.
Can you see my slides?
Yes, we can see very clearly.
Okay, thank you. Bismillah ar-Rahman ar-Rahim. With the name of Allah, the most beneficent, the most merciful. And thank you very much for allowing me to share our experience in this historic Centurion webinar. I am going to share what we do in our setup in Pakistan and during our missions in Pakistan as well as in Afghanistan. And he's my mentor, Professor Khalid Durrani. And there are different etiologies of the short palate. Sometimes there is congenital palatal insufficiency, or sometimes there may be scarring after palate repair.
Professor Fayyaz, sorry for the interruption. Would you like to put the slide into full screen mode?
Okay. Is it good? No. Okay. Thank you.
Thank you. That's perfect.
Yeah. Thank you. So in congenital palatal insufficiency, the normal velum which fails to close the nasopharynx from oropharynx due to short anteroposterior diameter. And this short velum is the main cause of the nasal speech in otherwise normal palates. So there are different types of CPI. There may be absolute shortening, relative shortening in cases of when the pharynx is too deep. Patient may be syndromic or non-syndromic. And the cleft palate is a pathology that can be seen, felt, and heard. However, CPI is better heard than seen or felt. And how we can confirm a competent VP closure? We can have a cold mirror in front of the nares and ask the patient to speak and ask sound. If the closure is incomplete, there will be clouding of the mirror. And there are mainly three components. The speech is nasal because there's a nasal air emission, there is hypernasality. Patient cannot pronounce the word S. There is shortness of breath during speech as the air leaks continuously through the nose. Patient cannot blow the candle unless they compress their nares. The approach has always been to be multidisciplinary. Speech pathologists, orthodontists, and plastic surgeons, they are the key players to examine this very patient. And we can ask the patient to say hamper to measure the pressure flow testing. We can have static radiographs. We can have multi-view video fluoroscopy, nasopharyngoscopy, CT and MRI studies. Then there may be non-surgical management and surgical management. The non-surgical management, usually they are indicated in mild VPT cases. Speech therapy is always the main force to be used. Then it is the non-invasive. However, it cannot help severe VPT cases. In case of surgical management, mostly indicated in moderate to severe VPT cases, pharyngeal flap, sphincter pharyngoplasty, furloughs phaletoplasty, a buccinator flap are the permanent solution to improve speech outcomes. However, sleep apnea is one of the main concern. Then when we compare different surgical techniques, pharyngeal flap taken from the posterior pharyngeal wall, it can cover large central gap, it is effective for large gaps, and it has high success rate. Sphincter pharyngoplasty, it can, the proponents claim that they can create a dynamic sphincter using pharyngeal wall muscle. It can narrow the velopharyngeal port by repositioning the palatopharyngeal muscle. It is indicated mainly in lateral gaps. Furlough-palatoplasty can be used to lengthen the soft palate, mainly indicated in short palate or in short velum with congenital palatal insufficiency. It can improve the length of the palate. Then someone can use injection of the filler material in the posterior pharyngeal wall. However, it is limited use and it's not a common procedure to be done. Then in case of pharyngeal flap, there is a great risk of sleep apnea. There may be hyponasality. And then when we compare speech therapy with prosthetic procedure like palatal lift process, speech bulb obturator, speech bulb obturator can fill the velopharyngeal gap, and it is indicated for the large gaps or for the patient who are not fit for surgery. However, it can help the patient to have a good voice, but sometimes it is uncomfortable for the patient to keep it for all the time. So most commonly used procedure are furlough-palatoplasty, pharyngeal flap, sphincter pharyngoplasty, or buccinator myomucosal flap. However, whenever we want to do a pharyngeal flap, we always do modified Muller maneuver. We ask the patient to close the mouth and breathe rapidly with a partially closed nose. If the patient has severe difficulty to breathe, pharyngeal flap is contraindicated. Now, how we can compare different types of pharyngeal flap according to the width, spirally based and inferiorly based, and according to its shape. So decision to choose the type of pharyngeal flap, narrow or wide, is always taken after consultation with speech language pathologist. We usually follow Professor Low's paper. So when the width, 50% of the width of posterior pharyngeal wall is used, we call it narrow flap. Medium, when 2/3 of the width of posterior pharyngeal wall is used, and wide, when 90 to 100% width of the posterior pharyngeal wall is used. Spirally based flap is much more comfortable. It has a higher base and a longer flap can be taken. However, it may be difficult to revise the lateral ports. Inferiorly based pharyngeal flap, I have never used it, but the proponent says the surgery is easy and it is easier to revise the lateral ports. However, the flap is short and it cannot be used in patients having with wide VPI gaps. Quadrangular versus triangular flap. Quadrangular flap, the donor side cannot be closed. Flap is inserted inside the soft palate. There are chances of cyst formation. I usually use triangular flap. The donor side is always closed primarily, and the flap is placed between the split ends of the soft palate. We always use a cocktail of xylocaine with epinephrine and tranexamic acid for local filtration anesthesia, and we balloon out the posterior pharyngeal wall, and then we wait for 7 to 10 minutes to have good vasoconstriction. We always use the triangular shape pharyngeal flap. However, we never go beyond more than 60% of the width of the posterior pharyngeal wall. That means we leave 20% space on each side for breathing. And using these criteria, we do not have problems of obstructive sleep apnea in our patient population. I asked my staff to give me a data. We did 481 pharyngeal flaps from 2021 to 23. And we called many of our patients back for follow-up speech recording and examination. We had 2 patients with complaints of sleep apnea. 1 patient improved with use of nasal decongestant drops, while other patient needed revision of the lateral ports. In the last 15 years, we had 3 pharyngeal flap patients to revise the lateral ports. Snoring is usually common, but it usually goes away within 2 to 3 weeks. However, sleep apnea is always there if we go more than 60% of the width of the posterior pharyngeal wall. If there is sleep apnea, some surgeon would like to divide the pharyngeal flap and they can do furlough-palatoplasty to improve the VPI. So I'm sharing some of the cases. Short palate with nasal voice, our marking, split the soft palate and the pharyngeal flap in a triangular shape. We split the soft palate. We dissect the levator and then we elevate the pharyngeal flap. We suture it to the superior end of the split soft palate. We close the donor defect primarily with a running continuous suture. And then we suture the lateral side of pharyngeal flap to the nasal layer of the soft palate on both sides. And then we suture the levator at the base of the pharyngeal flap, taking a good bite of the superior constrictor muscle. And then we close the oral layer. We always ask the patient to take liquid diet for 3 weeks, water, milk, milkshake, yogurt, juice. And then we also advise organic honey 3 to 4 times daily with no water intake for 15 minutes after the honey intake. Post-operative, some more patients using pharyngeal flap. An adult patient, another patient, very wide gap, but still we were able to close it with pharyngeal flap. Another wide gap. Now I'm going to share some videos. This patient had a fistula at M3 region and the palate was short. So we revised the palate and we added a pharyngeal flap at the same stage. We separate the oral layer from the muscles and the mucosa. We are raising the pharyngeal flap and you can see we are leaving ample amount of tissue on both sides for breathing. We suture the tip of the posterior of the pharyngeal flap to the split end of the soft palate anteriorly. Now we are going to close the donor side primarily with a running continuous suture. We are suturing the nasal layer of the soft palate with the lateral side of the pharyngeal flap on both sides. Suturing on the left side. We are dissecting the levator on the left side. Suturing the levator on the right side. Now we take a good bite of the posterior from the right levator to the base of pharyngeal flap and the left levator. To start up the oral ear closure, we usually use running continuous suture. We go to the next patient. This is a short palate patient. And the length of the palate is short, and you will see how we can lengthen the nasal layer as well as the oral layer of the palate. Yeah, now you can see the incision goes below. So we can lengthen the nasal layer, and we can also use the lengthened oral layer. We are going to raise the pharyngeal flap. We never go beyond 60% of the width of the pharyngeal wall to avoid sleep apnea. Sleep apnea will always occur when we go beyond 60%. I still remember some of our friends, they use 90% of the 100% of the width of the posterior pharyngeal wall. Those patients are always bound to get sleep apnea. Closing the donor defect primarily with using 3-0 or 4-0 Weichel sutures. Closing the right side with the pharyngeal flap and the leather of the soft palate. Closing on the nasal layer on the left side. We are going to start the closure of the oral layer, and we go as a running continuous suture. So we go to the next video. This is some mucus cleft palate patient, but the age of the patient was probably 14 years. So we have a policy, we add pharyngeal flap at the same stage to improve the velopharyngeal function. We split the soft palate, we raise the pharyngeal flap. We are going to close the donor defect primarily with a running continuous suture. Now we are going to show a bilateral complete cleft palate repair. As the patient was in adult age, so we did the pharyngeal flap at the same stage. Some lengthening of the soft palate. Lateral incision on right side, lateral incision on left side. Raising the right mucoplastic flap away from the palatine shelf. Doing some dissection of the pedicle as well. Dissection on the left side. The pedicle has been radically dissected on both sides to facilitate medial movement of the both mucoperiosteal flaps. Start of the closure of the nasal layer. the section of the elevator on left side, elevated section on right side, elevating the pharyngeal flap on the posterior pharyngeal wall, suturing the tip into the anterior portion of the split soft palate, closing the donor defect in the posterior pharyngeal wall with a running continuous suture, suturing the nasal layer, suturing the nasal layer on the left side with the lateral side of pharyngeal flap, suturing the levator with the taking good bite of the superior constrictor muscle. We usually put 3 sutures to the muscle, and we wanted to keep the muscle fixed posteriorly as far as possible. Start of the oral layer closure. Oral layer closure completed. The speech improvement is very good after adding a pharyngeal flap. They're good intraoral pressure for pressure, consonant, fricative. They're decreased or improved hypernasality, intelligibility is improved, and the voice quality is restored. As many surgeons say that it takes as little as 45 minutes to change the life of a cleft child forever. However, Professor Brian Sommerland says it takes even less than 45 minutes to ruin the life of a cleft child forever. So you can see many of the patients with major deformities losing the precious tissue during the primary palate repair. And it takes hours of difficult and thoughtful surgery and many months to rehabilitate the patient. And I'm very much grateful for your patience. Thank you very much.
Thank you very much, Professor Fayyaz, for all your valuable videos that you've shown us, especially over the years. And next, I'd like to invite Professor Low.
Sorry, can I?
Professor, yes, but you're not in full screen yet.
Okay. So is it okay?
Yes.
Okay, thank you. Thank you to have this opportunity to talk about our experience of surgical treatment for the velopharyngeal insufficiency. And as we know that the velopharyngeal insufficiency in my practice, most of the patients come from the after the cleft palate repair, and also clinically we have patients with submucous cleft palate, either classic or occult, that because of follow-up, patient develop VPI, then we schedule surgical intervention for the VPI. Or I also have the patient with congenital VPI. Here congenital, we mean that we cannot find any anatomical problem, but patient have VPI. And also I have patients after palate tumor surgery or radiotherapy. And finally, we have a VPI patient after previous VPI surgery. So I will talk about some of the so-called the redo VPI surgery. Well, I think the method for correction of VPI has reportedly several methods in the literature. In my practice, I wish to have a simple treatment protocol for the VPI. And also, we know that the successful treatment of the VPI should be defined as resolution of hypernasality and also with minimal morbidity, particularly the airway. Our protocol, as you can see here, that we start to have speech evaluation and therapy approximately 3 years of age. And we typically treat patients with VPI if there is two stage, two timing. One is in the preschool age, that is between 4 to 6 years of age, or at 9 years of age when we do the alveolar bone grafting. After the adenoid involution, there may be another group of patients develop the VPI. Or we also have patients when they become adult, they have VPI after the orthodontic surgery. Physically, I think we should be careful that to look at the muscle orientation or if there is associated oral nasal fistula. And also very important to have the hearing test. And also patient have, if there is any dental malocclusion, and this is especially patient adult may have malocclusion and speech issue. Here you can see a patient in the left side. This is a typical classical submucous cleft palate, while patient on the right side, you don't see a central or midline translucent zone, and this is, but you can see the hard palate notch, and sometimes you can see the bifid uvula. So this is, we call it occult submucous cleft palate, and also this group of patients may have VPI that require surgical intervention. So we always have our, after our clinic, surgeon can screen the patient first and then refer to our speech pathologist to have perceptual evaluation. And we always have instrumental assessment if the patient have clear hypernasality, and our speech pathologist will schedule nasopharyngeal scope to evaluate the VP closure. And this is our typical perceptual assessment. And I think our speech pathology can do this very easy, and seems that the children can feel relaxed and talk to the to our speech pathologist, but not in my clinic, because I don't feel that the patient can feel easy in my clinic. And also we do we used to do several kind of instrumental speech assessment, such as nasopharyngeal scope, nasometer, or video fluoroscope. But now we focus on nasopharyngeal scope because our speech pathologists feel that they can accurately make the correct diagnosis without using the video fluoroscope. So nasopharyngeal scope is our main instrumental assessment if patients have hypernasality. And we define the VPI as marginal or inadequate based on the finding. If the closure ratio is higher than 0.7 or 0.8, we call it marginal VPI. For the closure ratio less than 0.7, then we call it inadequate. And then we, based on this category, we schedule select our surgical technique For example, furrow for the marginal or pharyngeal flap for the inadequate VP function. So although in my practice, I also try several, such as listed here, but now we only do two kinds of procedure. One is double opposing Z plasty for the marginal VPI, and then pharyngeal flap for the moderate to severe VPI. And I used to do sphincter pharyngoplasty, but I don't think that in my hand I can have good results. So now I shift and doing only pharyngeal flap if the VPI is severity is moderate or to severe. Now, if VPI was associated with oral nasal fistula, then I might repair the fistula if the fistula is large, or I can do simultaneous repair the fistula and the VP surgery. Certainly, our speech pathologist will do nasopharyngeal scope evaluation and then decide if a simultaneous repair can be performed. This is our furrow double opposing Z plasty for the marginal VPI. And I designed a large Z plasty, and now I use a curvilinear rather than straight line incision, and make a large Z, start with the lateral close to the hemular process area, and the dissection in the nasal side is just the opposite. So I feel that between the straight line or curvilinear line, the difference is that I can have a longer soft palate using the curvilinear incision. So I think this is a typical that the myomucosa flap turn posteriorly, and then mucosa flap turn anteriorly, and this is the nasal side, and then follow the nasal side, the oral side, the opposite way, so that we achieve the muscle reconstruction and also lengthening of the soft palate. So you can see after the surgery, actually you can see the scar of the Z plasty, and also the long soft palate after this procedure. Now, for patients with moderate to severe VPI, where the closure ratio is 0.7 or below, then we do a modified pharyngeal flap. And now we need to be careful that design of the pharyngeal flap is typically superior base, and the width depends on the severity. And then we close the donor side, and I also develop a mucosa flap, the distal base from the nasal side, so that I can completely close the raw surface of the pharyngeal flap. Remember, I think this is very important, that you don't want that the pharyngeal flap pedicle is left uncovered, because that will end up with a fibrotic band, and then shrinkage of the pharyngeal flap and opening of the lateral port. And so the effectiveness of that operation will be reduced. So I think to completely close the donor side without leaving any raw surface is key to have a successful pharyngeal flap surgery. So after the surgery, actually, all the nasal side and also the donor side, and as well as the flap pedicle is well covered and no raw surface. Then how do we choose the velopharyngeal procedure, and as I mentioned that I feel important thing is to consider how I can adequately close the velopharyngeal port without having mobility, especially the nasal airway obstruction. I think in our patient, we really don't like, and our patient will be unhappy to have obstructed nose. So that's why we have two procedures to choose. Certainly speech outcome is important, but compared to the nasal airway, I think we still have to be careful in selecting the procedure. Is the closure pattern matter in selection of the procedure? Well, it is reported like this, but I personally do not follow this suggestion. And also there's a paper reported that there's no difference between the pharyngeal flap or sphincter when the closure type is corona or sagittal. So that's one of the reasons that I choose pharyngeal flap for the moderate to severe VPI. As I mentioned that the adequate VP closure and nasopharyngeal airway is both important factor component that we need to balance these two things when we choose the VP surgery. Then we reported our protocol that based on the closure ratio, and we choose double opposing Z for a closure ratio 0.7 or higher, or a pharyngeal flap if the closure ratio is less than 0.7. And well, I do not like to have a wide pharyngeal flap because then the patient will have obstructed nasal airway, and so I will tell patient that if your closure ratio is very low, at most I can do a median width of the pharyngeal flap, and you may have some residual hypernasality, but your VP closure could become, I mean, your nasal airway will still be good. So we have these 84 cases. We have very interesting the biphasic distribution of the VP surgery. One is in the preschool age, and the other group is in between the 9 to 10 years of age. This is after adenoid resolution. And in that period, I found that my individual improvement rate for the furlough is 80% only, but the pharyngeal flap have close to 95% of effective VP closure. So we actually are now improving our furlough procedure. However, if you look at the airway associated complication, and we found that the double opposing Z plus C has lower airway issue. However, pharyngeal flap has higher snoring or sleep dysfunction. So if we have a marginal or mild VPI, I think furlough is the way to go. So this is our protocol to choose the VP procedure after the palate repair. Now, we actually have modification to improve the success rate of the furlough for the marginal VPI. And I will do the report later on because I think one modification is the curvier linear incision to replace the straight line incision, and the other modification is to add buccal fat into the anterior part of the soft palate, and this will reduce the fibrosis and reduce the shortening of the soft palate, and this can significantly improve the our success rate using the double opposing Z for the marginal VPI. Now, another group is the repeat VP surgery. This means that we do VP surgery already, and then patients still have VPI developed. So how do we do? If patient had previous fellow procedure and we redo the double opposing Z, if the diagnosis is marginal VPI. However, if the diagnosis is moderate to severe, then we will do pharyngeal flap. If the patient have a previous pharyngeal flap, and then we may do a redo pharyngeal flap division of the previous PF. If the pedicle is low, or if the pedicle is location is okay, then we do hemisphincter pharyngoplasty, and this is our method to choose the procedure for the repeat VPI. And this is some of you may wonder that what is the effectiveness of the redo double opposing Z if a previous furlough was performed. I think if you can see the drawing here, that the muscle could be pushed back a little bit more, but it still can be a good closure of the VP port. Maybe most importantly is the lengthening of the soft palate. So that's why we redo the double opposing Z, still can effectively close the VP port and achieve adequate VP function. And this is in one of our paper. We found that before the surgery, for the marginal VPI, and we redo the double opposing Z, we have a good acceptable success rate after this redo furlough procedure. And I mentioned that if the patient had previous pharyngeal flap and the pedicle location is higher than C1 level, then we don't need to divide and redo the pharyngeal flap. Instead, we do hemisphincter pharyngoplasty. Depends on which port has the worst closure ratio. We can do one side of hemisphincter pharyngoplasty or both sides of hemisphincter pharyngoplasty. That really depends on the nasopharyngoscopic evaluation by our speech pathologist. And this is also a very interesting procedure for this not uncommon situation. And we have this hemisphincter pharyngoplasty before the surgery. We have altogether 17 cases, and then we found that after the surgery, we achieved quite a nice result after this hemisphincter procedure. So I would like to make this conclusion that our simple classification for the VPI is marginal or inadequate. And for the marginal, we choose double opposing Z. For the inadequate, meaning moderate to severe VPI, then we choose pharyngeal flap. I think using this simple protocol, we actually, over the year, we had quite a nice, acceptable result. Thank you for your attention.
Thank you so much, Professor Lo, for that amazing lecture. Next, we would like to go on to our Q&A session, and big kudos to Professor Sommerland and also Professor Flores for already answering some of the questions that the audience have for you guys in the chat room, or else we wouldn't have enough time to go through all of them. But okay, so I'd like to welcome all four of the speakers to join us now for the Q&A session. And we'll start with our first question. And I'll ask each one of you to answer these questions So the first question is a question from Professor Akira Yamada, and the question is, could you tell us about the timing of surgery for submucous cleft palate? Some people advocate late surgery, but that might end up with some VPI surgeries. So I know Professor Sommerland already answered this question, but would you like to repeat your answer for the audience, please?
Yes. So a baby, where a baby has been diagnosed after birth with a classical submucous cleft, if that baby's having major feeding problems, I would repair that palate at the same time as I would normally do a palate, which for me is about 6 months, but between 6 and 12 months. If in doubt, wait and ask the speech pathologist to assess routinely at about 18 months. And if at that stage the child is not developing pressure sounds and has evidence of VPI, again, I would operate at that stage. Otherwise, wait, and some of that VPI doesn't become obvious till they're a bit older. But if at any time, if the speech is affected, and finally, there's the group who are asymptomatic and then have an adenoidectomy by an ENT surgeon who's not recognized that they have a submucous cleft. So those are the 4 ages. But I would have a low threshold for operating on submucous clefts, particularly the classical ones.
Thank you, Professor Sommerland. Professor Flores, would you like to add anything?
I think I'm more conservative than Mr. Sommerland. I operate on VPI. There's a lot of patients with submucous cleft palate who I don't operate on. I wait for a clear functional problem, usually related to speech. And typically those patients, the vast majority that I have operated on is when they're a bit older, maybe 5, 6, 7 or older, when they have a specific speech problem. I have intervened earlier, as early as maybe 3 or 4, when there was a very clear speech problem, but this was all indicated by my speech therapist. We have all our patients who come to our unit seen by speech and feeding specialists from the time of infancy when they see us. And I have not yet, although I've been doing this a bit less time than Mr. Sommerland, I've yet to need to feel that I need to operate on someone for feeding purposes for a submucous cleft palate. Maybe that will come, but we haven't felt like we need to intervene for that indication.
Thank you, Professor Flores. Professor Fayyaz, what's your protocol for this type of patients?
Actually, because in low middle income country, the patient typically present too late, and we have still lot many patients who report to us at 6 years, 10 years, 15 years, or even after 18 years. And I still remember that we did a mission in Multan probably in early November, and we operated a patient with submucous cleft palate who has a congenital palatal fistula, and his age was 22 years. So in our setting, we usually always add pharyngeal flap with the submucous cleft palate with the idea that the speech would improve dramatically. We already published a paper in Annals of Plastic Surgery in May 2021. We had 170 patients with unilateral complete cleft palate, and they were all more than 6 years old. In one group, we just repaired the palate. We did Bardak 2 palatoplasty. In the other group, we added the pharyngeal flap. The speech pathologist was blinded. He did not know what procedure has been done. Listening to the speech of the patient, his opinion was that the patient who were given pharyngeal flap primarily with the palate repair, they had better speech outcome. They needed lesser number of speech therapy sessions, and their fricative, their plosives were very good as compared to the patient who were had only palate repair. So in submucous cleft palate presenting late, we always add pharyngeal flap at the same stage, and we have literally very good encouraging results.
Thank you, Professor Fayyaz. And of course, Professor Low.
Yeah. Well, I would wait until the patient had the speech insufficiency, is a speech problem, And the better timing is to wait until 4 years of age when our speech pathologist can do nasopharyngoscope. Then I can choose a better method to correct the VPI. But before the 4 years of age, if the mother concern too much, and also our speech pathology can confirm the hypernasality, then I will just do a regular regular size of Z plus G for the double opposing Z fellow procedure.
Thank you, Professor Low. Next, I'd like to ask a question from Professor Tensipak. And the question is, what is your protocol for adult unrepaired cleft palate patients? And just to change it up, I'd like to start with Professor Low. We'll work our way backwards.
Yeah, I think this is a very interesting issue that I always talk to our collaborative surgeon when I do the mission, and they have a lot of adult unrepaired cleft palate. Usually, I would recommend. It depends on age because usually, in my experience, before 6 years of age, I would do a follow palatoplasty to repair the unrepaired cleft palate. But after 6 years of age, especially if an older child, 12 years of age, and I believe that we have to add a pharyngeal flap in addition to the palate repair. So, but I don't have many such kind of case, so I always encourage my colleague in the Asian country to do this study. But basically, I would divide between before and 6 years of age or up to 12 years of age to decide if a pharyngeal flap is required.
Thank you. And Professor Fayyaz?
Actually, when we started doing missions in Pakistan, we had a very increasing number of adult patients reporting to our outpatient clinic. Initially, I used to repair the palate only. But our follow-up speech pathologist findings were that because the patient has been used to speak in a wrong way for many, many years, it's very difficult to de-learn the way he has been speaking. So we started adding pharyngeal flap and our results improved dramatically. Because in the adult patient, even the oral hygiene, even the dental hygiene is not that good. And the adult patient do not follow the instruction of the surgeon as good as the mother of a small kid who has been given instructions. So we usually feel more convenient to add pharyngeal flap. It will also reduce the tension on the repair side. It will lengthen the palate. It will reduce the nasal air emission. It will reduce the hypernasality. So we always prefer to add pharyngeal flap whenever we get an adult patient.
Okay, thank you. And Professor Flores?
Thank you. So my co-panelists have a lot more experience than I do in terms of doing this type of work and in more of an outreach setting. But what I would add to the conversation is that someone who is an adult who's had an unrepaired cleft or a cleft palate that was poorly repaired, and they're used to speaking with a non-functional palate. Even if you put the palate together, they will have numerous articulatory problems or many speech errors. So if possible, that patient would really have to be followed by speech therapists to address those issues, and the speech results will have to be tempered compared to that of a younger patient, as Dr. Fayyaz and Dr. Low has implied. And the other thing is that doing this kind of surgery in an adult, in my opinion, has a higher incidence of wound breakdown and fistula, instance of fistula, which will compromise your speech result, which will compromise your functional results of the surgery. And I think those patients you have to keep a bit of a closer eye on. I think if you take 100 patients, you do this at an adult age, and 100 patients do it at the time of infancy, the fistula rate, the wound breakdown rate is going to be much. And I think that part has to be really kept in mind and should affect your post-operative protocol and your discussion with the patient.
Thank you. And Professor Sommerland?
Yes, I chaired a working group before the Chennai international meeting, and with representatives from many parts of the world, India, other parts of Asia, South America, and the consensus view of that group, and we had some very interesting discussions, people like Jostamurti and Mukunda Reddy and Nivaldo Alonso, and the conclusions were by that group that yes, it's worth doing, that most of these patients are not restored to normality, that they will improve their VP function by sort of 1 grade, and their self-esteem is also improved, and feeding may be better. You know, eating curry when it's entering your nasal cavity must be quite unpleasant. So my own experience, and obviously not as experienced as Professor Fayyaz, but in working in many low and middle income countries, is that I think there are 2 important prognostic signs. One is the articulation, which has been mentioned. If these patients have severely glottal articulation, and especially if they don't have access to intensive speech therapy, then their speech is not going to be dramatically changed. Second prognostic sign is how active are their palate muscles. And it's interesting, if you look at unrepaired palates, you see some patients you look in their mouths and they have really dynamic palate movement and a lot of pharyngeal wall movement. Others, it's as though the palate's given up. It's just not doing anything. And I'm interested, and we actually suggested a prospective trial following that workshop. It would be interesting to look at those 2 prognostic features and see how that does correlate with outcome. But I think the conclusions of that group, and it was published in the Cleft Palate Journal, was yes, it's worth doing, but don't expect normality, and warn the patients that their lives are not going to be transformed.
Thank you. Our next question is from Professor Tanikawa, and the question was originally for Professor Fayyaz and Professor Low, but I like to ask all the experts anyways. So the question is, do you recommend dividing the pharyngeal flap in case of OSA, or do you follow any other protocol for post-op divisions? And after lengthening, do you think VPI will not recur once the flap is divided? So Professor Fayyaz, would you mind answering this question?
Yes, actually, in our series, because we have never gone beyond 60% of the width of the posterior pharyngeal wall, because we always feel if the speech has improved, let's say to a moderate level, and still the patient has some nasal air emission, it's much better than a very good speech but with obstructive sleep apnea. Because sleep apnea is a very, very difficult stage, difficult scenario for the patient. So whenever we feel that there is sleep apnea, I have revised 3 patients where we have enlarged the hole, and I usually do not divide the pharyngeal flap. I would go to enlarge the hole on the lateral side, and that should be sufficient.
Thank you, Professor Fayyaz. And Professor Low, your opinion on this?
Yes. Usually when I divide the pharyngeal flap, I think the indication if the patient complain severe sleep disturbance, typically obstructive sleep apnea, then I would not hesitate to divide the pharyngeal flap. However, if patient wish to keep some speech function and still complain nasal airway obstruction, then I may enlarge the portal by some so-called cutting the port, the upper part, to enlarge the port without division of the pharyngeal flap. The other indication is that when I do the orthodontic surgery, and if our anesthesiologist have trouble to do intubation, then I may also divide the pharyngeal flap. So this is the timing indication when I divide the pharyngeal flap.
Thank you, Professor Low. Professor Flores, would you like to add?
Yes, it's interesting. I see a failed pharyngeal flap, meaning either creating obstruction or not improving speech or both. It's really about diagnosis. You can take it down, you cannot take it down, but you could have pharyngeal flaps that are too low. You could have pharyngeal flaps that are too wide and creating obstruction. You could have pharyngeal flaps that are done and there is a V-shaped deformity to the muscle. And in fact, they would benefit from a re-repair as a salvage while dividing the pharyngeal flap. And I've done the arrowhead technique while taking down a pharyngeal flap. And I have increased the size of the ports, as Professor Lowe has said. So I think this is a situation when I am confronted with it, is where I really have to make a diagnosis. And earlier in my career, I said, oh, I would just take it down or something like that. But now I'm very intentional about my physical exam, about what I see on nasoendoscopy, about how they sound in speech and how they're breathing. And depending on what they do, I may do a variety of things. The last patient that I took down the pharyngeal flap, I ended up doing an arrowhead, but that's what they needed because they were still short and they had a V-shaped deformity. And she doesn't need anything else, right? But it's really about diagnosing. And as I mentioned before, the categories of what they need.
And last but not least, I'd like to ask Professor Sommerland to give us his opinion.
Yeah, so I do very few midline pharyngeal flaps for the reasons that I've discussed. I've seen many flaps in different parts of the world which are very disappointing. Some tether, and you actually improve, as Roberto says, dividing the flap, which is actually counterproductive because it's pulling the palate down, and doing a muscle repair, that's certainly an option. I think one of the problems with pharyngeal flaps is timing. You're relying on pharyngeal muscles rather than palate muscles to do the closure. And often when I've looked at posterior pharyngeal flaps, endoscopically, they look as though they're closing, and yet the speech is very significantly nasal. I think that's a problem of timing. And my final comment would be that I think the incidence of airway obstruction is underestimated. If you start doing sleep studies, and Professor Lowe, you've done lots in Taiwan, when you start doing the sleep studies, the incidence is much higher than you might expect. Don't rely on the patient to complain. And so you published a paper yourselves, 90% OSA after midline pharyngeal flap. So I think it's an underestimated problem that we shouldn't forget.
Yeah, Brian, I do really agree with you that if we do objective sleep study, the incidence of obstructive sleep apnea could be very high. But basically, in my practice, I rely on subjective patient complaint. If patients do not complain, they are happy with the sleep, happy with the speech, that I just observe the patient. In my practice, sleep study is not easy to arrange. So this is one of the reasons.
Okay, thank you very much for our very esteemed all the professors from United Kingdom, from the United States, Pakistan, and my mentor, Professor Lowe. And really appreciate all of you sharing your own experience. And really, really very nice to all of the speakers give us a very nice protocol based on the length, based on the functional, based on the any kind of shape of the pharynx types. So we have very, very nice discussion, even though Professor Fayyaz and Professor Lowe still presenting. Lots of discussion already be done in our children already. And thank you, Professor Brian and Robert already answer your very nice solutions to all those problems. I'm PY. I'm really appreciative for all your dedication to those cleft care. I know VPI is always cannot be easily be solved. It's a really not only the physical problem, it's a more over kind of a mental problem as well. So not only be treated by surgeons, I hope we should be establish a very nice comprehensive team to go and support with everybody together to treat those the patient we need. So thank you for your coming to join our 100 times of ICC together today. Good morning and good evening. Thank you, Brian, Robert, Ghulam, and Lun-Jou. I hope you guys can turn on your screen to join the group photo together. Okay? Thank you very much. Thank you very much. So I will count to 3. And actually, I saw a lot of very good experts in speech, surgeons, Professor Hamda, Daniela, James, especially Akira Yamada, Professor EK, yes, Professor Luca. Yeah, so I will count to 3. Please give me a big smile. 1, 2, 3, cheese.
Cheers.
Okay, very, very nice. And hold on. I have the second page, please. Today we have lots of audience. Okay, count to 3. Give me a smile. 1, 2, cheese again. Cheese. Okay. Thank you very much. And good morning and good evening. Okay, thank you, professors Brian, Robert, Ghulam, and Lun-Jou. Thank you, Junior. Thank you, everyone. We are going to our next 101 ICC webinar 3 weeks later. Thank you very much. Bye-bye.
Thank you. Thank you so
Bye.
much.
Thank you. Thank you very much. Have a good day.
Thank you.
Ooh, thank you, Professor Fayyaz.
Yeah,
Thank you,
thank you. My
Professor.
pleasure. My pleasure.
Okay. 好了，Junior 辛苦了。
明天见，明天见。
OK，明天见。See you tomorrow.
See ya.
Bye. Thank you, Natalia. Thank you, Samuel. Bye.